Good afternoon, everybody. Assalamu alaikum wa rahmatullahi wa barakatuh. Now we'll start the session number 3, which is talking about the hair and nail disorder, gonna presented by many lecturers from world around the world. So first, we're gonna start with the Dr. Michelle Strasser. She's talking about the alopecia areata with JAK inhibitors and why. So welcome, Dr. Michelle. So briefly, Dr. Michelle Strasser, she's assistant professor, dermatologist at the Department of Medical and Surgical Science in Italy, and she's belonged to the University of Bologna. So welcome on board.
Thank you so much for the invitation. Thank you all to be here. And we'll talk about, we have the, here, okay. We'll talk about alopecia areata and which JAK inhibitors we can use and why we have to use it. So today we have especially the possibility to choose the JAK inhibitor on the basis of the age and the availability of the drug in each different country. But to understand why we have to prescribe a JAK inhibitor, we need to understand the pathogenesis of the alopecia areata, and only this way we can choose the best JAK inhibitors. So to choose the JAK inhibitor, it's important to understand, to recognize different forms of alopecia areata, to distinguish the clinical approach, the clinical manifestation, and to distinguish which form we can use it. Then we have to explain to the patient everything about the use of JAK inhibitors and choose the right choice, the right dosage. So we start with the definition very, very quickly about the typical definition of alopecia areata as an autoimmune disorder, as today it's absolutely confirmed, and it is a very worldwide hair disease. You can see we have 0.1, 0.2% of the prevalence in all the world. And it is an autoimmune disorder with a genetic predisposition. A lot of genes are already individualized to recognize the typical alopecia areata. But the most important, as in the last period, the recognition of GWASS, because it is related to the typical action of the JAK inhibitors. For this reason, maybe there are some persons that can be more useful for them, the use of JAK inhibitor for this type of patients. On the other side, in this patient, we have a trigger event. The trigger event are very many different. It is not important, the specific. They induce the increasing of the interferon gamma, and this is activate the typical effect, inducing the loss of follicular immune privilege. The immune privilege is very important on the follicular unit. You know, there is this important phase that permit hair to remain. When there is this automatically arrive, this inflammation due to the presence of the interferon gamma, we have to reduce completely. We lost this privilege immunity, and for this reason there is the secretion, as you can see, of the interleukin 15 that induce really the clinical aspect of the alopecia areata. And for this reason, all the JAK inhibitors are very indicated to block this channel of the JAK is 1, 2, or the selected way as a 3. And after this loss of the immune privilege, we have the typical clinical manifestation. In the alopecia areata, we can have the patch alopecia, the total alopecia, or universalis alopecia. In this case, the last two are the typical severe form of alopecia areata. And when we have to approach with the severe form of alopecia areata, we have to consider the prescription of the JAK inhibitor on the basis, first of all, of the age, because they are possible to prescribe after 12 years old. Then it's important to understand which is the period, the first onset of the alopecia areata, and the duration of the actual episode, because it is indicated the severity and the possibility influence on the response. Finally, don't forget to have all the aspects of this your patient to understand, to prescribe JAK inhibitor. It's important to understand if there is any other autoimmune disorder associated and the status, because we need to have also the blood examination before and during the treatment. So today, in fact, the patient is not only here. It's a very important classification. We have to look at it on the clean row of the hair brown, hair lashes. So we have to start with a typical SALT examination. Then we have to correlate all the other important indicator of the severity of the disease. Only in this case, we have the typical aspect of alopecia areata. We can prescribe JAK inhibitor. So it's a very long step before to prescribe it. All of us start with the SALT. SALT is very easy, clinical assessment. We have to describe it as a severe form. On the other side, we have to also look at it, especially on the hair, but then we have to move with the clinical, with the typical impact of this loss of the hair brown, hair lashes, nail, and all the psychological aspect. For this reason, today the scale to indicate the step, the really severity, and so the prescription of JAK inhibitor is the alopecia areata scale. So we have to look at the clinical, we have to move versus the sensitive area as hair brown, hair lashes. Then we move with the typical answer to respond to therapy, the activity of the disease, and the psychological impact. The increase of the severity is completely different if all these steps are together in the same patient, even if you not have a very totalis or universally patient in front of you. So this is today our patient, because don't forget the loss of the hair diffusely change completely the impact, the psychological problem. For this reason, last year, the ASAMI group, it is an international group of hair experts, describe all the different things, all the different important points that you have to consider it when you have to select the right therapy. The right therapy is last year, very recently approved by, again, international group of European hair experts, listened by Professor Rudnicka, that describe all the important expert consensus on systemic treatment. And you can see JAK inhibitor is indicated also in non-acute as a second step when you have especially the failure of the glucocorticoid steroid. When you can indicate the failure of any treatment, when you have some months before to start the typical first-line therapy as a steroid, as immunotherapy, but after 1 year of failure of this treatment, don't take more time and start directly to JAK inhibitor. The rationale of JAK inhibitor is in alopecia areata is to induce the block of the inflammation that we described before. And you know that we have different family of JAK inhibitors. All these molecules can be selective or not versus the typical site of the hair follicle. And during the time, you can see all the important steps that describe by different publications where it is the position of alopecia areata, because a JAK inhibitor induces the activation directly, the block of interleukin 15 and interferon gamma that we described before. For this reason, how it is important to understand the mechanism that induce the alopecia areata. So oral JAK inhibitors have shown greater efficacy in treating alopecia areata until today, better than the topical inhibitor, that there are some studies about it. It's especially indicated in failure of previous treatment, and the most common side effects are especially infection of the upper tract, respiratory or urinary tract. Don't forget that all the side effects can be reversible when you stop the therapy. Don't forget also that we started with 11 new molecules in the last years, but today not all these molecules are available. For this reason, we can have in Europe, especially the approval of baricitinib and ritlecitinib, and very soon it is possible to have the uroxolitinib. So it's important, all the studies, they induce a very statistical significant hair regrowth, but especially we have to understand which is the specific site to understand the role of each JAK inhibitors. As you can see, different paper, this is a very important picture that describe all the real role of JAK inhibitors. JAK inhibitors are a very different trial that conduct the efficacy and the regrowth phase in alopecia areata. You can see all the most specific action of the JAK inhibitors and the possible side effect. In the last year, we have especially the approval as a principal approval because it's the first one of the baricitinib, then we have the ritlecitinib, and very soon again we have the approval of ruxolitinib. So in Italy, so in Europe, we are available for only the 3 that are indicated in patients with severe form, so more than 50% of the involvement of the scalp. In ritlecitinib, you can start from 12 years old, in baricitinib only in adult. All the drugs are approved by the important trial, the Allegro study for ritlecitinib and the Brave study of baricitinib. And they are indicating the study because they have a very specific site. You can see the baricitinib is not specific. It can block directly all the JAK, 1, 2, and 3 JAK. On the other side, the ritlecitinib can induce the blockage of the JAK3, so it's very selective. On the other side, also the TEC family that induce the tyrosine. So it's a very important site to block. This is all the study of the Lilly, of the baricitinib. You can see that is one of the first papers that is approved in the New England Journal. And the speed of regrowth in this type, it's a very different. In the course of the study, we noticed that there is 3 types of different patients: early patient, gradual patient, and late patients. So they classify also this, and we try to understand if the onset of the disease, the duration of the last episode can influence this response of the therapy. And they have a very good result in severe form, with the result that can induce the improvement that to reduce the SALT from 90, 95 to 20. This is the SALT score that we have to take in consideration when we have a growth response. In addition, we have a clinical response also until the 152 weeks. And also, don't forget that they try to reduce the dosage or stop it. Some patients can worsen it, but after they retake again the drug, they start again to regrowing. On the other side, the other possibility is ritlecitinib with the Allegro study, where we have again a very good response to arrive on the SALT score 20. This is the good. Also in the ritlecitinib, we have different trajectories. You can see that describe again the early patients, so who respond very soon, versus in the middle of the gradual, and finally the last that is the late responder. Here we grow maintain in the study through 2 here in most of the patients, you can see. And don't forget, in both cases, hair lashes and hair brand can be very soon. It's one of the first time can induce a very regrow faster than the scalp. The safety profile of ritlecitinib, the baricitinib, is well known in these years. We have a very good response, and as I told before, it's especially on the respiratory tract and the urinary tract in both cases. And finally, we have the ruxolitinib that is not well approved, is not well approved in Italy, but they arrive in this trial that is Striver 1, as you can see, and again a very good result in hair regrowth. So the practical approach in JAK inhibitors and alopecia areata is first of all to select the candidate, more or less 12 years old. Then we have the SALT score, then we have the psychological approach. We have to do all the important request examination, the clinical important management. Don't forget to take in consideration some side effect. So today I will choose on the basis of the age and the basis of the availability of because the effects are very similar. So don't forget, when you have a patient in front of you, that you have to prescribe JAK inhibitor, explain the cure, explain that it's a chronic course, explain the result, because it's possible to have time to have this result, and don't forget to send it in a specific center. In Italy, we start in July 2023, and we have a very good response in our patients. And we learn about the JAK inhibitor, that it's important to to not take too more time to select. Start as soon as possible, because when the duration is too much, the possibility of regrowth is lost. So what we change in our clinical practice is a female. She started with a lot of traditional therapy in here, but without any response and no other regrowing. Now you can see after 6 months of JAK inhibitors, very good response. After 1 year and a half, you can see a very good. So we have to take, this is a free care in Italy. You have to visit every 6 months, 1 year. We have also to have a very good tolerability, and you have to, don't forget, only the lowering of the cholesterol. So in young patients, in women patients, take in consideration the pregnancy. And finally, we have to also to take in consideration the risk of the upper respiratory tract infection, viral infection, and you have to take in consideration all the blood examination. Don't forget, what happens in the first 4-5 months of treatment does not get worse over time. The result is very slow. We have to describe 3 different types, as you can see, and it is possible to require several months. Eyelashes and hair brown can be the first sign of regrowing. This is what we can understand on the literature and our experience. And we confirm all the study of the literature. So we can describe 3 different forms: early, gradual, and late response. So don't forget to stop if you have 9 months of no response, because it is possible to have very late responder. In these cases, also trichoscopy can help you to distinguish that is a regrowing phase. It's not to have to stop it, but only to wait. So at the end, it's important to take your time, take the time of the patient, and don't take too much time to start a JAK inhibitor. If you have a very good response, don't forget that today the hair regrowth is a cosmetic regrowth, not a total regrowth. It's possible that some patient after, also late patient, you can see after a few months, they can have a good regrowth, but sometimes they remain. What we have to do with this patient, with the SALT 20 that remain in this patient? We have to understand that the SALT score 20 is a good response in patient with the JAK inhibitor. So we have to understand what we have to do in this case, because we can add the previous treatment that is confirmed also in expertum consensus. So thank you for attention. This is a kind invitation, if you like, with my mentor, Professor Piracino, of anicoscopy and trichoscopy. Thank you.
Thank you, Dr. Michele, for the updating in JAK inhibitors. Very interesting. Now we'll move to the second lectures, which are going to be presented by Dr.
Good afternoon. Next talk will be Professor Lida Rudnick. Professor Ruda Rudnick, member of the Board of Directors of International League Dermatologists Societies and member of Board of Representative of ADV and Honorary President of Polish Dermatology Society. She is the head of the Department of Dermatology, Medical University Warsaw, Poland. Her scientific achievement consists of almost 400 publications. The main scientific achievement with Professor Rudnicka is her contribution to development of trichoscopy for diagnosis hair and scalp disorders. She coined the term trichoscopy and co-edited Atlas of Trichoscopy and organized the first World Congress of Trichoscopy in Warsaw, Poland. Her clinical interests focus on hair diseases, including alopecia areata, and she is honorary member of several scientific societies. Welcome, Dr. Rudnicka.
Thank you very much, and hello again, everyone. Ladies and gentlemen, there is a small city in the Dominican Republic, and this is unusual in that sense that in this place there is no androgenic alopecia, neither in men nor in women, but specifically no androgenic alopecia in men. So it was long a mystery, but now we know they have a congenital disease which is causing the 5-alpha reductase deficiency. So these people have no androgenic alopecia. They generally do not have much body hair, and they develop their genital organs, their phenotype, the male phenotype, during puberty and not earlier. But let me take a look and draw your attention to the hair. So if they have no androgenic alopecia, maybe by causing a 5-alpha reductase deficiency, maybe we can also induce a world with no hair loss, or at least no hair loss because of androgenic alopecia. Well, before I go into details, let me just remind you that 5-alpha reductase is an important enzyme which plays a crucial role in androgenic alopecia, most probably, but probably not only, but most probably mainly by inducing the production of dihydrotestosterone, and dihydrotestosterone is inducing the miniaturization of the hair follicle and of the hair. Because we all know androgenic alopecia is not a disease of hair falling out, it is a disease of hair becoming smaller and thinner. So the thought is that if we can decrease the activity of 5-alpha reductase, then maybe we can treat or even prevent androgenic alopecia. Well, are there any ways in clinical practice? Yes, there are. Many of them we are using in our daily life as dermatologists. We can use oral, topical, or intralesional treatment approaches. Regarding oral, this is finasteride, dutasteride, some plant extracts which are available as diet supplements, and some anti-androgens which are not available either in Europe or in USA. I am not sure, but probably they are not also available here. The topical treatments are finasteride, and then again one more topical treatment which is available only in selected countries in South America. And intraregional dutasteride, I will comment on this in a moment. So when looking at the efficacy, and the efficacy is by reducing the activity or the concentration of dihydrotestosterone, here finasteride is giving a decrease, a reduction of serum level of dihydrotestosterone by 70%, dutasteride even more. However, the other ones are on a lower level. So finasteride and dutasteride are the main players in androgenic alopecia, and we use them in everyday practice. Regarding the title, My Approach to Androgenic Alopecia, this is a simplified approach I take in most cases of androgenic alopecia, in most patients with androgenic alopecia. I usually start with minoxidil together with finasteride. In women, I use a higher dose. In men, I use a lower dose. I know that some of my colleagues are using a lower dose of 1 milligram when they treat patients, but when they treat themselves, they use a higher dose. We use the dose of 1 milligram not because we are so happy with it, but we use it because this is the only approved dose, and this is the only dose for which we have as clinical trials. So this is the main reason. And if this is not effective, I would probably switch to dutasteride and maybe increase the dose of minoxidil. Some of my colleagues I know are starting with dutasteride. Whatever approach you take, I think it's the individual way to approach. I'm a little bit happy that I have co-written the first article about dutasteride in androgenic alopecia in a woman 20 years ago, before we even believed that this could be effective. Anyhow, what is important about finasteride and dutasteride, they both work during the time when the activity of 5-alpha reductase is highest. So they will be most effective in younger people, and the best efficacy is in women who are below the age of 50 and in men who are below the age of 40. Now, a very common question which is asked by patients who are reading Google, or even worse, they are learning medicine from ChatGPT. You probably know for medicine it is even worse than Google, because Google has true data and then ChatGPT. ChatGPT is giving you the information as a fact, but not mentioning that this is from a patient forum or from other source. So In general, the very commonly asked question is whether finasteride may be associated with breast cancer. Well, we all know that this comes from a story long ago of 4 cases of men who were treated with finasteride for prostate conditions, and they developed breast cancer. Later, there were several articles and no association between finasteride or dutasteride and breast cancer, either in men or in women, was found. And even there is now a very new article by my friend Marianne Senna and her colleagues, and she also has confirmed in patients who are using dutasteride or finasteride for dermatological conditions that the numbers are exactly the same in terms of risk of breast cancer, and even there's a slightly higher number of breast cancers in patients who are not using finasteride or dutasteride. So what is important is that with 5-alpha reductase inhibitors, we can have breast tenderness, we can have gynecomastia, but there is no breast cancer, no risk, no increased, of course, everyone can have breast cancer, but no increased risk of breast cancer. And there's even an opinion from a few years ago which shows that maybe there's a biological rationale for finasteride to be used as a prevention for breast cancer. Well, we do not have data for this, and to be honest, data which are available are contradicting these theses. However, I'm showing this as a wider picture of the point of view regarding breast cancer and finasteride. Many patients are asking about sexual adverse events. Here, there are data which indicate that there may be some increased risk of adverse events. There's no permanent sexual adverse event related to finasteride. And also the data are not slightly inconsistent, because if you take a look, in the group of dutasteride, placebo has a higher rate compared to finasteride itself. However, here again, placebo is lower. So some increased risk is possible, but what is important, it is not permanent, and there's no biological rationale to claim that it may be permanent. And data have shown that the risk of discontinuation of treatment because of sexual adverse events is similar to placebo. So there are some adverse events, but in most cases, they do not cause the patient to discontinue. Few words about the plant extract. The plant extracts, they are available over the counter. They are registered as diet supplements. There are many of them. Some of them have some proven efficacy in the biological activity regarding its anti-androgen activity. None of them really, or to a very slight degree, they do have some information about androgenic alopecia. Most of them don't. They are based on the fact that they have their sales are based on the fact that their ingredients have some anti-androgen activity. The most well-known is salm palmetto. It is controversial, and the urologists, they have banned salm palmetto from using in prostate hyperplasia. It does have some activity which is decreasing the serum level of dihydrotestosterone, but it also has a wide range of activities which are anti-androgenic but not selectively associated with 5-alpha reductase inhibition. However, because it does have an effect on 5-alpha reductase activity, it also may have a teratogenic effect, which is important because some of our patients have the feeling that if it's a diet supplement, it's safe. No, there is no such proof that it is safe in terms of pregnancy. Few words about spironolactone, an old drug, but the data about androgenic alopecia are quite new. In our country, only the oral form is present. The dose, which is recommended, is between 25 to 200 milligram. Most of the dermatologists using approximately 100 milligram. I myself, I usually start with a lower dose and then I go up if I need. However, this is not my first-line treatment. I use it when I cannot use any other approach. The gel and the solution is not available in our country. Few words about the topical treatment. Regarding the topical treatment, the most fresh information is about topical finasteride. It has been already on the market in Italy and the Scandinavian countries. The topical finasteride has been already on the market for several years in Italy and in some Scandinavian countries. Now it is going wider. It is already available in my country, and the sales are starting in other countries. It seems this is spray, and it seems that the effect of the topical finasteride is similar to the oral finasteride. However, what is important to keep in mind with using the topical finasteride is that there is a penetration of the finasteride to the bloodstream, so that topical finasteride is detectable in the serum in a dose-dependent manner, and also it decreases the blood levels of dihydrotestosterone. So again, for those of our patients who would believe that there are no adverse events, and especially that there is no teratogenic effect for women, there is no proof, and just the opposite. It is absorbed, so it may have adverse events. I have written about the teratogenic effect, which is related to women. The drug or the medication is approved for men only. However, I know that many women are also using this type of treatment in countries where it is available. Few words about intralesional dutasteride. The problem is it is effective. There are some literature data on the efficacy, and also there are some data, including the recent paper by Jerry Shapiro, which show maybe it's not so effective. However, the main problem I see here is that the form, which is for injections, it is not approved by FDA or EMEA as a medication. They are on the market as cosmetics, or they're on the market as medicinal devices. However, we are injecting a medication which is not approved as a medication, so this may cause some legal problems. However, the views on this here differ between experts and also between lawyers. So with this summarizing, I'm showing again my approach to the treatment of androgenic alopecia. And what is most important, I always start treatment when I'm sure about the diagnosis. Why? Because there are so many diseases which may mimic androgenic alopecia. Also, the 6 patients in this image, they do not have androgenic alopecia. And about some of these diseases, I will be talking just in a moment during this session. And if you would like, please feel invited to take a look at my YouTube channel where I talk about hair diseases and trichoscopy. Thank you very much.
Thank you, Professor Rudnicka. It's an excellent presentation on androgenic alopecia. It's very comprehensive. Thank you so much.
Now we're going to move to the third lecture of the hair and nail disorder. We're going to present by Dr. Michele Strasser, and she's going to talk about the oral minoxidil in alopecia areata. When do I use it?
So thank you again, and we have the last slide of previous talk about the possibility of regrowing alopecia areata due to any type of drug. And today we notice that this regrowing phase is a cosmetic regrowing. It's not a really totally. So it is possible, we started from the last of previous, that not all the patients, also with the JAK inhibitors, can have the regrowing phases. So it's possible to have this SALT 20 that remain. In these cases, we can use a different approach to better permit regrowing in this last part of the scalp. And we start again with the paper of the spertum consensus listed by Professor Rudnicka that try all together to describe the most important approach in alopecia areata. And you can see we have to start here where it is especially the activity of the alopecia areata, so it is a chronic phase, is acute phase. In these cases, the use of oral minoxidil or local minoxidil is important in this type of patient, independently when we have to choose another drug that can induce the stop of the activity. So there are a lot of agents that are very useful for alopecia areata, and the use of minoxidil is always suggested in any cases to block the activity, to help to block the activity, to enhance the regrowing, and you can use topical and oral minoxidil as adjuvant therapy. We have to take in consideration a different approach in minoxidil, different side effects, but all of them are very easy to manage. Don't forget about it. So the use is very important in any case in alopecia areata. There are not a lot of publication about this, the use of specific, because minoxidil is from the past, from the always, it's indicated in the in 2015, as you can see, there is one of the first article about the use of oral minoxidil, in this case in androgenetic alopecia. So minoxidil is a very oldest drug, you know, and it is used only in a locally application, and while the oral application is only very more recent, is 10 years from now. And the dosage can move from 0.25 to 2.5 milligram. The efficacy is very important on the basis of the dosage, and the most important side effects are hypertrichosis. It's more frequent in female, not so well visible on male. In general, minoxidil is an antihypertensive drug. It's the action until now on the hair follicle is not well described, is not well understood, but is the activity of to open the potassium channels, maybe induce this vasodilator effect directly on the hair follicle. We start from the beginning with the different dosage. We can have the 5% that is indicated in men patients and 2% that is indicated in female patients. Until now, we have 40 years of experience about efficacy and safety of the use of this drug, very, very high level. How do you prescribe local minoxidil? So the history is 30 years, and we know that we can use 1 millimeter 1 or 2 times per day, 2% or 5%. We have to apply it in dry scalp, so not wet, without any type of massage. It's very important. And don't forget to not wash your hair for 3 hours later. We have to also to take some special consideration. It is recommended frequent shampoo because the excipient that induce the absorption of the minoxidil, so the propylene glycol, can induce the aspect of like a dandruff, so you have to remove it with a frequent shampoo. No problem with the sun, because some patients decide to stop it during the summertime, maybe for any possible side effect during the exposition. No, absolutely, you have to continue it for all your life, every day. Wait 2 hours almost, especially for female patients, to go to the bed, because the possible contamination to the pillow and the possible hypertrichosis due to the contamination, not due the effect of side effect of the drug. And don't forget it is possible to be irritative on the scalp, especially in patients with seborrheic dermatitis, because it's an alcohol solution, so it's possible to have this irritation in patients with an inflammatory scalp disorder. So today the indication is important to have especially intermediate hair. This is all our aspect in androgenetic alopecia, but it's the same also in alopecia areata, when especially there is the regrowing phase, the starting of regrowing phase. You can enhance this regrowing phase to faster. It's also important to risk any compliance, especially in young patients, because it's not easy to apply 1 time, 2 times per day the application, the drug. This is some example in androgenetic alopecia with a very good result. Don't forget, in female patients, you can use 2% 2 times per day or 5% 1 time per day. And it's possible to have a hypertrichosis, especially in female patients. When you have the prescription of oral minoxidil, we know that today the data confirm the use of 2 milligram per day. In the women, it is better to start with the low dosage, and then you have to increasing during the time from 0.5 to 2 milligram per day. It's better to use before to go to sleep. Special consideration, avoid in patient with a very important heart disease, especially because it's a general effect of vasodilator. Don't forget, it's not a problem with the hypertension in a patient without any problem with the pressure, with the blood pressure, because it's not any effect if you have hypertension or normal. It's important to take in consideration only if the patient already taken other hypertension, because it's possible to have a combined effect of the two type of drugs. So only this is the real important. All the use of oral minoxidil is started many years ago with the study of Rod and Sinclair in Australia, and together with the last paper of the group of Spanish of Sergio Vano Galvan that induce the use of low dosage of oral minoxidil. It is a very important study. All the important experts are included in this study with a very large number of patients about this possibility. And all this multicentric study, very long study from January 2018, 2022, you can see 1,404 patients. And we can see a very high percentage of patients, more or less 80%, no adverse event. If you have an adverse event, you can see the most important 50 cases percent is the hypertrichosis. Other are very, very low effect. Very few cases are reported. Then we have this side effect. It is possible to have the adjustment of the dosage if you have this side effect. If you reduce, many of these effects can go away because it's a very dose dependent. The safety of the oral minoxidil is favorable because it is very good safety profile in general population. Globally, we have only 34% in general with the other paper. Altogether, the percentage 34% of hypertension. And also all this safety about the effect on the cardio system, it's well recommended in general recommendation, special question, you can see a recommendation. So where it is really not recommended, you can see in a case of a patient with a very severe degree of heart failure, severe renal disease, so very severe cases of these patients. In the past, we start again also with oral minoxidil androgenetic alopecia. I show you two examples of male patient with oral minoxidil 2.5 after 6 months, or in female patient, you can see 2 milligram in 1 year. But today we have to consideration, especially in female patients, the possibility of the hypertrichosis, and so you have to find the solution of this side effect. Eforlitin is one of the very important cream that reduce, or maybe the laser hair removal. It's possible to have water retention with edema of the ankle. In this case, you have to add the spironolactone, or it's very important. The dosage, you can move the dosage if you have this possible action on the pressure, and also you can use the add of potassium. It's very important in these cases. And don't forget, it is not any type of a tachycardia, so postural hypertension is very rare. How do you prescribe today oral minoxidil? In adult, but also in children. You have, especially in adult, in case of no possibility to use local for contact dermatitis, irritative or allergic, in patients especially that we have to enhance the effect of the other drug. Why the children? Children is the one of the last paper again of the Spanish group of Sergio Vano Galvan that confirmed the use only in very children, that also in this young patient there is not a lot of side effect. It's possible again only the hypertrichosis, the real great effect, but very one patient only decide to stop the dosage for other motivation. So in minoxidil in alopecia areata is a very few papers about this article. In this paper, we start again with this chart where we can see the use of oral minoxidil in alopecia areata. It is like adjuvant therapy, but in the paper, very recent of Lydia Rudnicka, it's described the use of it, of oral minoxidil. You can see in a lot of studies that evaluating the effective as a monotherapy in alopecia areata. They, in fact, study that the role of minoxidil is not only to enhance the regrowing phase during the regrowing phase of the alopecia areata, but you can use in a different way, because the effect in alopecia areata of minoxidil is, first of all, to open the ATP channel. That's very important, and this is an enhance of the oxygen effect and the growth factor delivery. On the other side, we have the stimulation of the prostaglandin, you can see, and in this case, we maintain the anagen phase, especially in patients that start to have a good, because spontaneous regrowth is possible also in alopecia areata. On the other side, we have also the activation, the moderation of the concanavalin A that induces the suppression of the T cells, that before we understand the role of the autoimmune disorder of alopecia areata, we have also the activity of the AKT pathway that is included in the event of the, again, of the inflammatory cascade that of alopecia areata, and also finally we have the significant downregulation of the interleukin-1 alpha gene expression. So on the basis of this article, what do the literature data say on this topic? That we can use absolutely minoxidil in alopecia areata in combination, but also alone, because it is well described locally, but also you can see also the oral effect, because there is a very good response in this patient or with this type of drug, especially with the comparison with the patient treated with a short period. So take in consideration to have this application or administration of minoxidil for a long time. Don't stop very soon. Take your time before to see the result of only therapy with minoxidil. Topical minoxidil is generally not recommended for a patient with form totalis or universalis. So if you have a very severe form, it is better to use oral minoxidil. Better than in case of patchy alopecia, where there is the severity is lesser, and it's possible to have a modification of the patch of alopecia is not so stable, different from the total universalis. The study started to use this drug with a high dosage, not 2.5 as androgenetic alopecia, but very high, like 5 milligram, 10 milligram, with a very good result. And I want to show some cases. This is a patient with together combination with high potency steroid at the beginning to stop the activity, and then to use only minoxidil to enhance the regrowing phase to maintain after 6 months. And this is another patient, after stopping topical immunotherapy, they started to regrow, and then you use minoxidil to enhance the velocity. And finally, this is last patient with the use only oral minoxidil 5 milligram per day without any other drugs. In this patient with a severe form alopecia areata, a very start of regrowth phase in 6 months. And thank you for attention. It's a kind invitation in Maine in Warsaw of the European Hair Congress Research organized by Lydia Rudnicka. Thank you so much.
Next topic is genetic hair disorders by Professor Lydia. Welcome, Professor Lydia.
Hello again. I promise it's my last presentation today. And I thought instead of mentioning all genetic diseases over and over again as we hear them usually, I thought I will start with a patient who visited my office yesterday. The patient was looking like this. This was a young woman in her 30s, and she started having alopecia when she was 12. There were several treatment options, including spironolactone, finasteride, and dutasteride, and many diet supplements. So, you know me, the first thing I did, I looked at trichoscopy. and it was not easy. So this is how it looked like. This makes it a little bit easier, but you know, there is a 10-second rule. If you know within 10 seconds, it's easy. But if you need more than 10 seconds, it's not so easy, and sometimes you need to think twice or three times, and here I was thinking 4 times, and then I looked in detail, and I saw these rectangular black structures. And the rectangular structures, they are typical for loose anagen hair syndrome. So I was thinking back and asking the patient about details, and it all fitted into the diagnosis. Few words about loose anagen hair syndrome. It usually affects girls. Usually it starts at the age of approximately 6 to 8. However, you have seen in our patients it started around the age of 10 plus. And there are some cases described where loose anagen hair syndrome had its first symptoms at the age of 2. And the disease is characterized by the hair very loosely being attached to the scalp. So just a gentle pulling is causing the hair to fall out. I will go back for a moment to show you a circus performance. This is the hanging hair hanging circus performance. And here the women are hanging on their hair and performing art. In any case, if this would have been a patient with loose anagen hair syndrome, this would not be possible because all hairs would fall out. Why is this possible? It is possible because the anagen hairs are very firmly attached to the scalp. So even hanging on the hair will not cause the hair to fall out. And this is a typical, let's imagine this is a typical anagen hair, very firmly attached to the hair follicle. In loose anagen hair syndrome, it's different. The hair is very loosely attached. So whereas if we imagine we need 100% of force to pull a hair in a healthy person, we just need 1/4 of this power to pull a hair in a patient with loose anagen hair syndrome. So the hairs are very easy and painlessly pulled. The patient does not feel it. So the patient is losing hair in many everyday life situations, like aggressive combing, sometimes pulling the hair, and sometimes even playing, usually playing with children, and the child is pulling the hair of the other child. So even minor hair pulling can cause hair loss. What is interesting, usually loose anagen hair syndrome clinically presents very similarly to androgenic alopecia. Please take a look at these 2 cases of diffuse hair loss, difficult to recognize or to differentiate from androgenic alopecia on the basis of the clinical evaluation only. Sometimes loose anagen hair syndrome may look like alopecia areata. When does it happen? Well, it happens usually when children play. One child, or here in this case it's a pet, one child is pulling the hair of another child, and then the child is developing a patch of alopecia. So here also, this is a differential diagnosis which needs to be taken into consideration, and this is one of these cases, one of the diseases, one of the genetic hair diseases where the patient would say, "Doctor, my hair never grows long." And indeed, very rarely the patients have long hair. Usually it is up to 5, 10 centimeters. We all know that there are some genetic hair diseases like monolatrix where the hair is never longer than 5 centimeters because it breaks off. And there's also other diseases. So there's a group of diseases where the hair never grows long, and this is one of them. There are some old criteria for the diagnosis of the disease. It's a positive pull test with at least 10 loose anagen hairs. I will just in a moment, I will describe the loose anagen hairs. However, a single loose anagen hair may be present also in a healthy person. But if there are more than 10 or more, this is already a suspicion for a disease. And in the trichogram, there are more than 70% of anagen hairs. The trichogram will usually reveal a predominance of anagen hairs, as mentioned in the criteria, over 70, but some authors say even over 80 or maybe over 90, and some experts say 100. What is typical is that because the outer root sheet is not firmly associated with the hair, so when the patient is pulling the hair, the outer root sheet is staying attached to the scalp, and the hair is pulled out without the sheet. So here in the upper two graphs, you see the hairs with the outer root sheet, and in the lowest graph shows a so-called naked hair, or a hair with no outer root sheet. Which again, if these are single hairs or if this is a telogen effluvium, we do not mind, it's quite normal. However, if we find many of them, this is already an indication of loose anagen hair syndrome. Also, we can see it in histology, probably rarely very so nicely as in this article by Rachita Durhat. And here we see very loosely attached the sheets, both the outer and the inner root sheet. So when we look at the rectangular structures in trichoscopy, and also now trichoscopy became an important aid in the differential diagnosis of hair loss, so probably we should think about modifying the criteria. So we think that these rectangular structures are not always so very rectangular, that these structures are the residues of the outer root sheets which stays attached to the scalp when the hair is pulled. Well, what about the treatment? Treatment, not easy as in all genetic hair diseases. However, the good news is that in most cases, or in many cases, loose anagen hair syndrome resolves spontaneously with age, usually over a few years meaning 5, 7, 8, 10 years. Unlike our patient who is over 30 and the disease is still not gone. It is believed that maybe the hormonal changes of puberty may have some influence on the hair being attached more firmly to the scalp. So one of our major suggestions for the patient is to avoid mechanical trauma, such as in the situation which I mentioned today as a cause of hair loss or as a cause of easy hair loss. We can also try minoxidil. Michela Starace was so nicely giving a summary about minoxidil. One of the indications may be loose anagen hair syndrome, and we may be impressed how well it goes when we try minoxidil in loose anagen hair syndrome. And this is one of the cases described in literature with 5% topical minoxidil. I think the moment the patient went to the doctor and the doctor recognized the disease, also it was suggested to avoid pooling. So maybe there are two elements which come in a combination. However, as you see, the results are very satisfying. And also we may ask about the low-dose oral minoxidil, and here there are also some cases published. An example is here. This is an 11-year-old girl who has loose anagen hair syndrome before and after treatment with 0.5 milligram per day of oral minoxidil. And there's a series of cases where the patient were treated with low-dose oral minoxidil. In most cases, the suggested dose was between 0.007 to 0.2 milligram. I am missing the milligram per kilogram per day. And with this finishing my presentation, I would also love to see you in Warsaw. We will have a lot of trichoscopy and a lot of hair disease treatment issues to talk about. And most importantly, I would like to thank very much for your kind invitation to Dubai. Thank you.
Thank you so much, Dr. Lydia. I would like with pleasure to introduce our next speaker, Dr. Azam Al Khalifa, a French board certified consultant dermatologist and assistant professor of dermatology at Qasim University, Saudi Arabia. He has a special interest in nail disorders and surgery. We'll talk about incorporating nail biopsies in dermatology daily practice.
Good afternoon. Moving to the nails, I will talk about practical points in nail biopsies, when and how to do them, and how to make it more representative and less painful. Starting with the anatomy, of course, the difficulty in nail biopsy is the nail plate itself. It is a hard keratin structure, so to penetrate it, to go to the nail bed or nail matrix is the main issue with the punches. But the most challenging point is the anesthesia before doing the biopsy. So just brief anatomy about the anesthesia. In each finger or two, we have 2 dorsal nerves and 2 ventral nerves. So when you want to numb them, you have to numb all these 4 points to keep it, because there is overlapping in the nail unit. Both right and left nerves, they meet at the center, and then the ventral and dorsal, they meet at the tip of the finger. So you have to numb all the 4 points to get a good anesthesia. And to numb it, you usually go with a needle with the same entry point. You numb the dorsal one, then the ventral one. Then you go to the other side and do the same thing. It takes 1 to 2 minutes, and it's very effective. Some people prefer to do the ring block. I have never done it in my life, and I believe it is a waste of time. It could be more comfortable, but I don't think that numbing directly at the distal phalanx is painful for the patient if we respect some points. Here are the sources of pain: the needle prick, the infusion of the anesthesia, and the acidity of lidocaine. So I always, before doing the anesthesia, I apply anesthetic cream under occlusion for at least 30 to 40 minutes. Then you go with a small needle, 30 to 32 gauge, and it is not painful. Then while injecting, don't be in a rush. Take your time, inject slowly, it will be less painful. And finally, the lidocaine itself, the pH is painful, it's burning. So I usually dilute it with sodium bicarbonate, 1 to 9 units, and it is very comfortable, and even I do it for some children and they tolerate it. So take your time when doing the anesthesia, always both sides, dorsally and ventrally. Then talking about the punches, we have different sizes. We usually say that if you do 4 millimeters or less on the nail bed, you don't need to do stitches. You still can do stitches, but if you don't do, it's okay. And 3 millimeters for the matrix, you can leave it without stitches. Direct biopsy. After the anesthesia, see here the tourniquet. This is very important when you do a biopsy or any procedure to the nail, because it is bleeding a lot. So with the tourniquet, you can do your procedure, you can do your stitches without any bleeding. The punch biopsy, either you take the nail plate with the nail bed or with the nail matrix, or you can do it after avulsion if you just want the nail bed or the nail matrix. Or the best, in my opinion, is to open a window with a large punch, then you go with a small punch and take the biopsy. Then you reapply the nail plate using some medical glues. These are the brands that are available for skin and for nails. You can use any of them. You reapply the nail plate and you leave it for natural healing. So in psoriasis, usually there is 2 parts. There is the keratosis part, but there is also the inflammation part. I'm talking here about nail bed psoriasis. You see the erythematous rim here surrounding the onycholysis. This is almost pathognomonic for psoriasis, and this is where the active psoriasis is. So when doing a punch, I usually do the erythematous border and the keratosis together in one punch. I rarely do biopsies to psoriasis because usually it is typical and you have dermoscopic signs that hint to the diagnosis. But when you need it, you have to do it in the right place. Inflammation and keratosis in the same punch. In lichen planus, it is more difficult because studies have shown that in lichen planus, 40% of the cases, the inflammation will be in the nail matrix only. and in 20% of the cases in the nail bed only. So you can do the punch and you will miss the diagnosis because you didn't do it in the right place, and you cannot know where is the right place. So the best biopsy for lichen planus is the lateral longitudinal biopsy. This way you will have nail bed, nail matrix, nail plate, and nail folds. And it is much easier even for the histopathologist to see the signs and to confirm the diagnosis. So same way of anesthesia and tourniquet, and then you just cut the lateral side of the nail, and the healing is usually excellent with minimal scarring. Some other indications where we do the lateral longitudinal is to do it for an excisional purpose. For example, if you do it to rule out squamous cell carcinoma at the lateral side of the nail, and same thing applies for onychopapilloma, but it is not lateral. In onychopapilloma, it is a benign tumor that arises from the matrix and goes all along the nail bed, so you have to remove the whole tumor here. It is benign, so you don't need to remove it if it is a typical onychopapilloma, but it is the only treatment for onychopapilloma. So same steps for anesthesia, but then you do the avulsion of the nail plate. You see here, I removed the nail plate. Then you cut the sides of the onychopapilloma, and then you free it from the periosteum because it is very adherent to the periosteum. Then you reapply the nail plate, and it is the natural dressing. You do stitches here along the onychopapilloma site, and then you reapply the nail plate. So same, but this time it is excisional biopsy. You remove the whole lesion. Here also, if you think about squamous cell carcinoma, for example, just do an excisional biopsy. You remove the whole tumor, and it is diagnostic and therapeutic in the same time. You know, if you have a lesion in the proximal matrix, you have more risk of scars. And this happens when you are treating, for example, melanonychia. You want to remove a lesion, but it is in the proximal matrix, so there is always a risk of scar if you touch the proximal matrix. And to know, before doing the biopsy, to know if it is in the proximal or distal matrix, you have to look at the free edge of the nail plate. So sometimes you have the pigment only on the dorsal surface, which means that it is proximal matrix, sometimes in the lower ventral surface, but in this patient, it was involving all the layers of the nail plate. There is even a destruction of the nail plate. Luckily, she was a younger patient, otherwise we would think about melanoma. But in these cases, when I saw this free edge, I expected that the lesion took the whole length of the matrix. And after doing the avulsion, that was right. Whole length of the matrix is taken by the lesion, and immediately I explained to the patients that there will be a scar here, because we will have to remove the whole thickness or the whole length of the matrix. But here there is another optional biopsy type. You don't need to remove the whole lesion to the whole thickness of the lesion or of the area affected by the lesion. You can do the shave biopsy. You just shave with a blade. You remove just the epidermal or the part that is affected by the pigment. Here I removed it, but you see the matrix here is without any color, so we removed completely the lesion, but we left parts of the matrix. And she sent me a photo later. Still, there is some dystrophy, but this is amazing. For the lesion I saw, when I saw it, I wouldn't expect that she will gain a nail again after the procedure. So shave biopsy is optional. If you want to remove melanocytic lesions, or even for onychopapilloma, you can do it the tangential way. Here is another example of a shave biopsy of melanocytic lesion. After removal of the lesion, there is no pigment remaining here. So, finally, we have challenges in all types of biopsies. First challenge is that it is painful, it takes time to heal, it is a surgery of the nail, and then sometimes with patients with comorbidities or children, you don't want to go for a surgery for just benign things, or if you are not sure that you need to remove it. So another solution is the clipping. We have some studies about clipping of the nails in some conditions. Not much conditions, only onychomycosis and psoriasis have been found to be helpful, and onychomatricoma also, but we rarely need a biopsy for onychomatricoma. You take a part of the nail and you send it for histopathology this time, not culture, or you just analyze it histopathologically. In psoriasis, it has been shown that histopathology with in onychomycosis, it was much higher in sensitivity compared to culture and KOH. So you can, if you are in doubt or if the culture is negative, you can send a piece for histopathology with PAS stain, and it shows the filaments of the fungi all involving the nail. But you need to cut the affected part. Here in this patient, we showed it this morning. The distal part of the nail is not affected by the stain of T. rubrum. It is not orange. So if you just cut this part, usually you will have a false culture, false negative culture, and maybe even in histology you wouldn't find the fungi. So you have to cut the proximal part of the nail to get the living fungi and to get a positive result. In psoriasis, again, same thing. You just do clipping and you send it for histopathology if you think about onychomycosis, for example, and they will find the same features of psoriasis without the PAS stain, without the filaments of the fungi. So another diagnostic helpful tool for psoriasis and onychomycosis. In onychomatricoma also it has been shown to be helpful, but the dermatoscope is helpful too, so you don't need the clipping. And if you are thinking about hematoma or melanonychia, this is also very helpful, but again, we rarely need the clipping or the biopsy for this indication. That's it. Thank you very much for your attention.
Thank you so much, Dr. Azam. We'll keep the questions till the end. So I'd like to present our next speaker, my colleague, Dr. Faisal Sbai from Kuwait. He's a French board-certified consultant dermatologist in Al Adan Hospital and Al Salam Hospital. He has a fellowship in nail and skin surgery, and he will talk about management of nail psoriasis.
Thank you so much. Thank you, Dr. INT'L, for the kind introduction. It's my pleasure to be here. I would like to thank Dr. Mohammed Ahmed and his amazing group for this great meeting. I don't have any conflict of interest, so again, I will talk about nails. This time, I will focus only on nail psoriasis. Okay, next. So as you know, psoriasis is a chronic inflammatory disease. It can affect not only the skin, it can affect the skin, the scalp, flexures, and the joints. Nail psoriasis, it's from 10 to 80% from the skin psoriasis, and up to 80% in psoriatic arthritis. Nail psoriasis could be presented in absence of cutaneous disease from 5 to 10% of the patient with psoriasis. Nail involvement associated with the greater severity of psoriasis, and nail psoriasis could be associated with decreased quality of life because the patient came with the pain, with the fissures, and some of them, they have a prevalence also of anxiety and depression. We can see it more in adults than in children, but be careful. We have also congenital nail psoriasis have been reported. Nail pitting and onycholysis, most commonly in children, we can see it. And nail dystrophy can precede the cutaneous involvement. Psoriasis, you know, it's a multifactorial disease. So with interplay with many genetics and environmental factors, resulting in inflammation cascade, expression of this cascade in nail fold, nail matrix, and nail bed can cause the clinical features that we see it in nail psoriasis. And because of the particular physiology and anatomy of the nail unit, there is a different clinical expression in nail other than in skin disease. You know that nail is a part of a difficult treating area, like the other diseases, like for example, like other area, like the scalp, palmoplantar area. So why nail is a difficult to treat area? Because of the penetration. If we give them topical treatment, it's difficult to penetrate through the nail plate. That's why sometimes we need to clip the nail to allow the cream to go through the nail plate. And because of the growth of the nail, so it takes more time, we have to monitor the patients. As we said earlier, so nail psoriasis could be a key indicator for psoriatic arthritis. So if you see any patient with psoriatic arthritis, look for their nails. And if you see nail psoriasis, look for their joints. Why is that? Because if you look to the anatomy, the extensor tendon, it's just close to the nail matrix. So if you see the nail matrix, it's just close to the joint. So that's why if you have inflammation in in the tendon. That's why they have joints involvement. So you will have most likely inflammation in the nails. So what we can see as a clinical features of the nail psoriasis. So that depends where is the inflammation. Is it in the nail matrix? Is it in the nail bed or in nail fold? So just to remind you again with the anatomy. So you know that if we talk about nail plate, we are talking, we are talking about the nails in general, we are talking about the nail plate abnormality. So nail plates originate from the nail matrix, here the nail matrix. Here we have the lunula reflecting the distal part of the nail matrix. And here we have the proximal nail matrix just beneath the skin. So this area, we call it proximal nail fold. And here we have the lateral nail fold. And beneath the nail plate, we have the nail bed. So that's why it's important to know it, because after that, you know where is the location of the inflammation coming with nail psoriasis. So as he said, Dr. Azam, so proximal nail fold here responsible for the superficial part of the nail plate. So if there is any problem happen or inflammation happen here in the proximal part of the nail matrix, so that will reflect the superficial part of the nail plate. If there is a disease happen here in the dorsal, in the distal part of the nail matrix, so you will see the inflammation you will see the nail abnormality in the ventral part. And if you have a disease happen here in nail bed, so you will have more with adhesion, more with the bleeding, other than nail deformity. So we know, so this is the inflammation happen here in the proximal nail proximal nail matrix. So in the proximal nail matrix, if you have the inflammation here, you will see the pitting because something happened in the superficial part of the nail plate. So we will see pitting. But if we have more inflammation in the proximal matrix, we will have trichonychia. And why we have trichonychia? Because the inflammation is so severe, because the proximal matrix is responsible for the mainly production of the nail plate. If we have inflammation here in the distal nail matrix, so what we will see the motile lunula. So as we said earlier, lunula reflecting the distal part of the nail matrix, and we can see also discoloration of the nail plate with leukonychia. If the inflammation here in the nail bed, we will see onycholysis. So we see oil spots or salmon patches. That means onycholysis in the middle part of the nail plate. And if we can see also onycholysis, distal onycholysis, and we can see as well splinter hemorrhage. So all of these signs reflecting the nail bed psoriasis. And we can see as well subungual hyperkeratosis. If we have the inflammation affecting the whole unit, so affecting the nail matrix, affecting the distal part of the nail matrix and the nail bed, so we can see the total nail dystrophy of the nails. So sometimes we have also paronychia. So this is paronychia, a chronic inflammation in the proximal nail fold because of the inflammation, not because of the infection, because sometimes we say paronychia, we are talking about infection. No, here we are talking about inflammation that cause chronic inflammation in the proximal nail fold due to psoriasis. Kopner phenomena is already in nails, so like the skin, so dominant hand most affected and the thumb most affected, and the toes, because of the friction, also could be affected more. Sometimes we can see super infection like Pseudomonas infection or fungus infection. Here we have Pseudomonas infection, so we call it chloronychia. That means the greenish discoloration of the nail plate. So here we have psoriasis plus bacterial infection. So for the treatment for this patient, we need to treat first the bacterial infection, then we treat the psoriasis. And here we have onychomycosis with psoriasis. Why we have onychomycosis with psoriasis? There is many explanations, like dystrophic nail, abnormal capillary units with psoriasis, or due to sometimes treatment like systemic or topical immunosuppressant. There is many variants. We don't have time to explain it all. We have keratodermatitis of Halepo, palmoplantar psoriasis, acropostulosis repens, Sapho syndrome. So mainly we need, we need to examine the patient. So we need to see the whole picture, not just focus on one nail to make the diagnosis. So mainly we don't need, we just need to examine the patient to reach the diagnosis. But sometimes we need to do biopsy, like he explained, Dr. Azam. So that depends where is the inflammation. If the inflammation in the nail matrix, so we need to do biopsy in the nail matrix. If the inflammation in the nail bed, so we need to do nail bed biopsy. For the treatment, nail psoriasis, as we said earlier, so it is a most challenging area to treat. There is multiple therapies there, so that depends on how many lesions. So there is topical, injectable, recommended for few lesions, and systemic treatment for more than 3 lesions, and if there is impairment of quality of life, and if there is skin or joints involvement. To summarize that, there is, if we have few lesions, like less than 3 lesions, we can start, if the nail matrix involvement only, we can start as a first line with steroid injection. So with steroid injection, we inject it through the nail matrix approach. So this is if there is nail matrix involvement only. But if we have nail matrix and nail, if we have nail bed involvement, we can start with the topical treatment. So first, it's better to do like clipping to remove the onycholysis, to remove the subangular hyperkeratosis, then to apply the cream. If we have less than 3 nails, and if we have nail matrix plus nail bed involvement, so here we can give topical and intralesional steroid. But if we have more than 3 lesions, here we can go with something stronger, so we go with systemic treatment. In systemic treatment, we have methotrexate, acitretin, cyclosporin, anti-TNF, interleukin 17, 23, Stelara, 12, 23, and apremilast and JAK inhibitors. All of them, they are working very well with psoriasis. Some of them work better than the other. So I will show you some data about some of the systemic treatment. Here in the GRAPPA meeting, they recommend, as we said earlier, they recommend TNF, interleukin 17, 23, Stelara, and apremilast as a treatment, as a systemic treatment for nail psoriasis. So I will talk about some of the biological treatment. Here we have a study about Cosentyx. So they found it's effective with nail psoriasis. And this is their photo before and after. And here we have the dose with 300 more effective than 150 and more effective than the placebo. They tested also in the pediatric age group with the same treatment with the interleukin 17 Cosentyx, and they found it is, and this is their photo, it's improved after the treatment. Here there is another study with another medication, TALS. They compared it with Stelara, both effective, but they found TALS more effective than Stelara, and this is their study. Here again, the same thing. They found TALS more effective than Stelara, but both could be prescribed for nail psoriasis. Here, apremilast as an oral treatment, oral phosphodiesterase 4 inhibitor. It's effective as well. They compare it with the placebo here. And the placebo group, they give them after 16 weeks the treatment, and they found all improved with the treatment after apremilast. And this is a case report of 2 cases, and this is their photo before and after apremilast. Here, before and after apremilast. So we talk about interleukin 17, we talk about Stelara, we talk about apremilast. Now we talk about Tremfya, Guzikimab, and they compare it with adalimumab, Humira. Both work well with nail psoriasis, but they found little bit more effective with Tremfya. And this is their study. So a little bit more effective with Tremfya, and this is their end result, 24 weeks, and here 48 weeks. JAK inhibitors, it's effective as well as a treatment for nail psoriasis. Here with the tofacitinib, again, they give, there's the two groups, one with the placebo, one with the treatment. Then the placebo group, they give him the treatment. Both improved after 52 weeks. Here, another case report with the upadacitinib, Rinvoq. They give it for psoriasis, nail psoriasis. And this is their photo before and after. This is week 0, week 16, and week 24. So I will give you just 3 cases from my clinic. I tried many of the biologics. I will show you some results. So first patient, he is a 31 years old male. He came to me with psoriasis and nail psoriasis with a strong family history of psoriasis. He received many treatment, topical treatment, then shifted to phototherapy. Then we give him at the beginning anti-TNF, then initially improved, but he developed secondary failure. So he has skin and nail psoriasis. So what do you think? What is the nail involvement here? What is the inflammation? Is it nail matrix, nail bed? Yes, excellent. So we have subangular hyperkeratosis and onycholysis as well. So hands and feet affected and the skin as well. So I give him Tremfya, interleukin 23, and this is 4 months after Tremfya, his skin become clear and his hands also become clear. So this is 4 months after. Also his feet, so no more subangular hyperkeratosis. And this is 1 year after Tremfya, so he sustained the same result. So this is baseline here. You can see subangular hyperkeratosis, and this is 4 months after, and this is 1 year after interleukin 23. Another patient, 16 years old, young girl. She came to me with psoriasis and nail psoriasis as well. First, she was treated with INT'L for 1 year without any response for her nail or her skin. Then we give her Humira. She showed some response in the beginning, then failed. So we decided to shift her to Cosentyx, and she has no any family history, or she has no any history of inflammatory bowel disease. So this is her nails when she came to me. So what do you think? What is her inflammation? Is it nail bed, nail matrix? Yeah, this is trichonychia. So she has a nail matrix involvement, and she has element of subangular hyperkeratosis. So we can say it is mixed between nail matrix and nail bed. So this is just after 4 months of treatment. I saw her recently, so I just have this photo. So we can see her nails become almost normal. The third case, my last case. So he came to me, a man of 45 years old, in our case psoriasis, nail psoriasis. He came to me, he said, "Doctor, please enough for the topical treatment." But when I saw him, he's still having mild disease. He's just having mild skin lesion here, and thighs and elbows, knees, so still mild disease. So I'm not willing to give him biologics. So what do you think? What's your approach here? What you will give? He said no more topical treatment. He's afraid. He said, "Doctor, please, enough is enough." So what do you think? What do you give him? So biologics, I don't think he's a candidate for biologics, still mild. So he said he wanted me something light, so I give him, at that time, a Primalast, so Otezla. I was thinking maybe it will work. I was not believing on it, to be honest, but I will lose nothing. I told him, I will give you a treatment, maybe you will have response. He said, "Okay, I'm okay for this, because I don't want to do any lab test. I don't want to apply any cream." So, and this is after, so this is still before. So you can see subangular hyperkeratosis, just mild disease, as we said. And this is 4 months after Otezla. So his skin become clear, no more active lesion, and his nail become normal. See, he has even long nail without any disease. So in conclusion, we have to educate our patients. So we ask them to keep their nails short, because if you have if they keep their nails long, they are more, they will have more dry nails, and combinal phenomena also will be there. So, and we have to tell them no trimming of the cuticle, and to clip their inequalitic nail plate, no acrylic nails, and to avoid combinal phenomena like if there is podiatric issue, they have to treat it. And no aggressive cleaning under the free edge, and we have to exclude onychomycosis or psoriatic arthritis. As we said, for the choices of the treatment, if there is few lesions, you can start with the topical treatment, but if you have more than 3 lesions with the joint and skin involvement, so we can go for systemic treatment. With this, I finish. So before I finish, I have to invite you all. Dr. Atlal is there. So we have, within 2 weeks, we have a conference in Kuwait. So this is the best time to visit Kuwait. So it will be during the weekend. So you are welcome to come with us. Thank you so much.
Thank you, Dr. Faisal, for the interesting lecture. Now we're going to move to the questions. So we ask for the speakers to be on the stage, please. Dr. Faisal, Dr. Michel, and Dr. Lydia. So any questions for the audience? Please give the mic to the doctor.
Thank you very much, everyone, for the interesting presentations. This was really very informative. My question is for Dr. Michela. If you have a patient who has only alopecia areata affecting the eyebrows or the eyelashes without having any alopecia areata patches on the scalp, what would be your approach?
Without the scalp, it's understand? It's a very locally. I think the best in Hebron is the intralesional steroid. Is the best one, the very approach, very soon the regrow is very good. On the eyelashes, you can use latanoprost locally, very good result. I think this is my approach, first.
Thank you. I have a question for you, Dr. Michelle, for the using of the JAK inhibitor. So I have few patients who's been on JAK inhibitor for a year, but 2 of them, like they develop severe acne eruptions. Like it's different than acne vulgaris. It's very sudden onset, severe nodules, painful. It turns more to have more post-inflammatory hyperpigmentations. So one of them, I need to stop the medications because it's painful, and the antibiotics is not working that much. So I have to shift here to isotretinoins. So my question is, it is safe like to combine 2 medications because both is working on liver? Or we need to stop the JAK inhibitor for a while, then we resume it gradually, or?
Okay, on my experience, the acne effect is a very not so severe to interrupt the drug in all my patients, but especially it is only at the beginning. It's not during all the treatment. Usually they improving. If you have this side effect, you can reduce the dosage of the JAK inhibitors. Very good result, and to understand. I think it is not an interaction with the other drug because it's a different mechanism. So it's important you have to continue to control the liver. If you have any side effect, you have maybe it is better to reduce or to change completely the antibiotic drug. I think it is not good to stop the use of JAK inhibitor, especially if you have a very good result.
Okay, thank you so much. Any question for the audience?
I got one question, Michelle. One patient I am giving him red lecitinib, that is Litfilo. Yes. Yeah. When is expected results are seen?
The aspect is as older JAK at very different, 3 different patients. It's a very early effect. It's possible, especially in Hebron, eyelashes from the 1st to the 3rd month of a therapy. Then some patients can have this gradually effect, maybe in the 4th, 6th month. And there is sometimes that can have a late effect, 9 months, 1 year.
So how long you are going to continue without results?
Yes, you have to continue to be waiting because some patients, and especially on the severity of the disease, the age of the onset in general of alopecia areata, and the stage and the duration of the last episode. You can have some late responder. So don't stop before, because there are some patients that require time to have effect.
Okay. One more question regarding minoxidil.
Yes.
Do you have any experience with higher percentage, around 10%?
Have experience of what?
Like topical minoxidil.
10%, not personally, but there are some study of Lydia, but especially of also Sergio. I know that the Spanish start to use 10 milligram, and there are some publication about it with a good result, not important side effect. Not personally, I never use it, not yet.
Okay.
I don't know, Lydia, if you use it, but not me.
But it's not available here. In some countries it is available. I don't know. Are there any advantages giving 10% or 5%?
Yeah, 5 milligram, it's wonderful. It's okay. I have a very good result. 10 milligram, I don't yet use it, but I don't know if Lydia have any result with the 10 milligram oral minoxidil. You started to use it?
10 milligram.
10 milligram?
I am afraid to prescribe more, but I have a patient who is taking 5 plus 3. So he's taking 5 in the morning and 3 in the evening. But I'm always telling him he's doing this on his own risk.
I have a question, Dr. Michela. You said no massage with minoxidil, no?
It's better for on my study not to massage, because you reduce the dosage, because you have on the hand, and then the massage induces the dirty scalp.
Okay.
So it is a very easy to apply the minoxidil, because it's a very intelligent drug. He arrived alone. Don't worry, like alone he can do everything. So.
And what about you using like a derma roller or derma stamp?
Yes,
Is
you
it
can
the same
use
thing like
dermaroller,
massage?
the microneedling, like this. Yes, you can use for androgenetic alopecia with a very good result. And then you have to apply at home your minoxidil, absolutely. It is better not to use for 1 day, because there is, an inflammation due to microneedling. And since it's possible, it is an alcohol drug, it's possible to have a very great itching and irritation. Maybe wait 1 day before to apply.
I have one question for Professor Lydia. What is your experience with the PRP and the Regenera for the androgenetic alopecia?
This is a very wide topic, because even though PRP is available, I think now for at least 20 years, there is still no standardized method. So everyone is doing a different company, different approach, different frequency. So it's difficult to compare. We did a small study with our patients, and we found that there is some improvement in 60% of patients. However, I always say, for many reasons, I always say it should not be used in monotherapy. For 2 reasons. I think this is a non-specific effect. So it improves the hair growth, but it's not disease specific. Second reason, I think that we have in our country many people who are not doctors, but they think they can do PRP because it's easy. So I always underline that this is an additional therapy to what has been prescribed.
Thank you, Doctor. Any other questions?
Yes. For Dr. Azzam, please. When you do the biopsy from the nail and you want to remove the nail plate, then you put it again after you do the biopsy. What is the aim to put it again? Is it physiological?
It's just a natural dressing.
It will fall, I mean.
For faster healing.
Just fast healing.
Yeah.
So you remove it, or the patient will remove it after that? I mean the nail plate.
Which one do you mean? If it is distal, I leave it and it will grow out. If you mean the window technique, I apply it with a glue and it stays in place.
It stays in place. It will not fall after that.
No, but there will be the mark of the biopsy, so it is not very aesthetic, but it stays in place.
Okay, thank you.
So we finish for this session today. Thank you for the doctors for the interesting lecture. Thanks everyone. Thanks for the audience.